All right, everybody, this is Hossein Maimani. I'm here with David Andorsky, who's one of our medical oncologists in the Boulder office. Today, Dr. Andorsky will be talking about updates and general information as far as non-Hodgkin lymphoma goes. He did his medical school training at Harvard Medical School in Boston. He stayed at Harvard and did his residency at the Brigham, and then did his fellowship on the West Coast at UCLA. David's been with Rocky Mountain Cancer Center since completing his fellowship at UCLA and has been nationally recognized as far as his research goes in the field of non-Hodgkin lymphoma. I'm going to go ahead and turn it over to you, David.
Okay, great. Hossein, thanks for that kind introduction. And it's always a pleasure to talk about this topic because there really has been so much progress in the past couple years with respect to treating non-Hodgkin's lymphoma. So I'm just going to share my screen here for a sec, and we'll go back to the beginning of the presentation. Yeah, it seems like every year when I give a talk like this, there's something new to report in terms of new progress. And I'll also highlight some of the involvement that Rocky Mountain Cancer Center has had in conducting some of the research in this area. So just to review, the lymphatic system, which is sort of the body system that this cancer, non-Hodgkin lymphoma, originates from, is designed to protect the body from infection. And it's an extensive network of lymph nodes along with lymphatic vessels that help the lymphocytes, which are the cells in the immune system, circulate, alert each other with respect to new infections, and then mount a response against any sort of infection. So it consists of the lymph nodes and the lymphatic vessels primarily. The spleen is in the left upper quadrant of the abdomen, is also involved in the immune system. I think of it as just a really big lymph node. And then some other extranodal tissues like bone marrow, skin, tonsils, and GI tract. The lymphocytes will circulate through those body tissues also as part of their normal functioning. As a result of that, lymphoma, because the lymphocytes are so widespread, when a lymphocyte goes bad and becomes a cancer, it can really manifest in almost any organ. So the majority of cases will have enlarged lymph nodes, and that's in fact one way that patients will often present is with enlarged lymph nodes in the neck or the groin or the arm. It can involve the bone marrow and the blood, which can cause low blood counts or abnormal looking cells in the peripheral blood. It can affect the GI tract all the way down from the tonsils all the way through the large intestine. It can affect the skin, the central nervous system, testicles, and even within the lungs itself or even within blood vessels. So those last ones are sort of less common manifestations, but it's really a disorder that can affect any part of the body. So this is a slide showing the WHO classification from 2008 regarding the classification of lymphomas. I don't expect anyone to be able to read this very small print. The point of this slide is to show you that how many different types of lymphoma there are. And this classification is continually changing as we learn more about the molecular basis of the disease, or the diseases rather, and how to approach them. So we're not going to talk about all 50 types of lymphoma today. We're going to focus on two of the most common types of non-Hodgkin lymphoma. The two that I'd like to talk about today, the first one is called diffuse large B-cell lymphoma, and the second is called follicular lymphoma. Both of these are classified as non-Hodgkin lymphomas and are derived from the B cells. Again, in the immune system, there are essentially two types of cells. There are B cells and T cells. Most non-Hodgkin lymphoma are derived from B cells. So diffuse large B-cell lymphoma is the most common lymphoma in adults. It is an aggressive disease, so patients will typically present with some type of symptoms, either weight loss or abdominal pain or fevers, and it grows quickly, and it needs to be treated fairly quickly, usually within a couple of weeks of someone being diagnosed. And it is fatal within a couple of months if people go without treatment. The flip side of that is that it tends to be a curable lymphoma with currently available treatments, so obviously that's not 100%, though as we'll talk about, there have been a lot of improvements in that regard. The other most common type of non-Hodgkin lymphoma is called follicular lymphoma. This is the most common indolent or slow-growing non-Hodgkin lymphoma. And it often grows very slowly to the point where some patients can often delay treatment for a long period of time. Some of these patients will show up with symptoms from enlargement of lymph nodes and things like that. Some patients, this is found incidentally. Somebody gets a abdominal CT for suspected appendicitis, the appendix looks fine, but there's some enlarged lymph nodes that are seen there, or they're in a car accident and they have some sort of imaging that reveals it. So some of these patients are entirely asymptomatic and can, in the beginning, be followed without treatment at all. The flip side, again, of it being indolent is that it's generally not considered curable with the currently technology, but the median, the average overall survival is more than 15 years with the current treatment. So it's best thought of as a chronic illness as opposed to an illness that's rapidly fatal. Most patients with follicular lymphoma do quite well. There is a minority of patients, probably 15 or 20%, that have early relapses, which we define as within 2 years of completing their initial treatment. And those patients tend to have more aggressive disease and an overall worse survival. And they've been targeted in particular by investigators to look for newer and better treatments for that particular subset of patients. So these are the two types of lymphomas we'll talk about today, some of the recent advances: diffuse large cell and follicular lymphoma. So diffuse large B-cell lymphoma, on the left, this is a slide showing the overall survival, the OS, for patients stratified by what's called the International Prognostic Index, or the IPI. This is a prognostic index that's derived from a number of different laboratory features and clinical features of the disease. That's not really why I brought the slide here. The slide is here just to show what the overall survival for this disease looks like. So patients that have low risk, 0 or 1 on that scale, have very good survival. There's 90% survival, 4 or 5 years down the line. But even the patients that have fairly high-risk disease still have a 50% overall survival. And again, most of the patients that are going to recur, that's going to happen within the first few years of treatment. So it's showing you that even with the standard first-line therapy, even for the high-risk patients, the majority of patients are going to be cured of their disease. The first-line therapy has not changed a whole lot in the past several years. It consists of R-CHOP chemotherapy. The R stands for Rituximab, which is a monoclonal antibody against a protein called CD20. That's been in practice for about 15 or 20 years. That was added to this backbone of CHOP chemotherapy, which is 3 chemotherapy drugs plus prednisone. That regimen has been around a very long time, 40 years or so. The only substantive improvement we've made to that for most patients was the addition of Rituximab, again, 15 or 20 years ago. There may be some newer data coming out about improvements upon this regimen, but right now this is the standard. And again, for the vast majority of patients, this does well and cures many of them. However, particularly for those high-risk patients, patients do recur. And then the question is, what are what we call the salvage therapies, the treatments you can use when they recur? The standard right now would be, again, Rituximab, the R, combined with some sort of chemotherapy. I put a couple of the initials here. Often when patients are having a good response, they will go into what's called autologous stem cell transplant, which involves giving very, very high doses of chemotherapy. Before you do the chemotherapy, you harvest their stem cells. The chemotherapy is so intensive that it essentially wipes out the bone marrow, but you've got their stem cells in the blood bank, and you can reinfuse them and reconstitute the immune system. This is sort of a high-tech procedure. It's highly immunosuppressive. But it can be curative in roughly 50% of patients who recur with diffuse large B-cell lymphoma. This type of approach is not particularly well suited to older patients, just because older patients tend to have more comorbidities and tend to tolerate this sort of intensive approach less well. Unfortunately, older patients tend to have more, the incidence of diffuse large B-cell lymphoma is higher among older patients. So there's really for a long time been a lot of unmet need in this disease, especially in older patients who aren't good candidates for autologous stem cell transplant, but also in younger patients who don't respond to their initial chemotherapy or who relapse after autologous stem cell transplant. So in the past 3 years, there have been 3 new drugs or combinations of drugs that have been FDA approved, and that's what I wanted to speak about today. Polatuzumab, Tafasitamab, which is really just a couple of months old, that approval. And then something that's been in the news a lot in the past few years, CAR-T, or chimeric antigen receptor T-cell therapy, which was approved in 2017. So polatuzumab is an antibody drug conjugate. So we mentioned earlier rituximab, which is a monoclonal antibody against CD20. So monoclonal antibodies have been in the news recently. If anyone's been reading about the president's bout with COVID, knows that he was treated with an experimental monoclonal antibody from a company called Regeneron. And the technology that we use basically can make an antibody against any target that you want. So the Regeneron thing for COVID-19 is directed against the virus, but before that approach was being used, monoclonal antibodies have been used to treat cancer, again, rituximab being the first one. The developers of the drug, the scientists, will decide what target they want the antibody to target. They'll develop the antibody, and then they can grow it in mass production and use it as a medication. So rituximab looks at the CD20 marker, which is on B cells. Polatuzumab targets a different target, which is CD79B. But what's different about this antibody is, in addition to being the antibody, which has these two binding portions that bind to the target, as well as this tail end, they've attached 4 molecules of chemotherapy. And the idea is that instead of giving chemotherapy the traditional way where it gets into every cell of the body, this is sort of a smart bomb or guided missile approach, where this antibody will get taken up by the receptor. It gets brought into the endosome in the cell, which is used for digesting things. And then the endosome turns into what's called a lysosome, which digests the antibody and releases the chemotherapy payload inside the cell. So it's, again, the chemotherapy is really inert while it's floating around in the body in this antibody drug conjugate form. It gets taken into the lymphoma cell, and then it releases the payload. And that allows a much more targeted approach with fewer side effects. So this is a technology that's been used to develop a number of different treatments. Again, polatuzumab is the first one that was FDA approved for the treatment of non-Hodgkin lymphoma. And this is a slide from the pivotal study that led to its FDA approval. This was a trial of BR, which stands for bendamustine and rituximab, which is a commonly used chemotherapy regimen. Patients were randomized to either get the addition of polatuzumab or no additional therapy. And this slide shows the results of that. This is what's called a Kaplan-Meier curve, where it shows the overall survival, again, the percentage of patients that are alive on the y-axis at any given time, which is on the x-axis. And you can see clear separation in these curves. The polatuzumab, which is the blue line, clearly did much better than the bendamustine rituximab alone, such to the point that about a year or so later, about half the patients were alive, whereas only about 25% were still alive after treatment with just bendamustine and rituximab. This was the first study in a very long time to actually show an overall survival benefit in this disease, and so it really made a big splash and was FDA approved fairly quickly, and now is part of the standard armamentarium for treatment of diffuse large B-cell lymphoma when the initial therapies aren't working. I'd also want to mention that one of my partners, Dr. John Burke, has been very involved at Rocky Mountain Cancer Center, has been very involved in clinical trials of this disease. Rocky Mountain Cancer Center participated in this trial. We also recently participated in a trial looking at adding polatuzumab to that R-CHOP, that first-line chemotherapy that we talked about earlier. And if that study shows benefit, then this drug may become part of the standard therapy for all patients with as part of their initial therapy for diffuse large B-cell lymphoma. But right now, this was a welcome addition to the armamentarium, again, for a disease that hasn't really seen a lot of new drugs for many years. The second new treatment is a different monoclonal antibody called Tafasitamab. This is an antibody against CD19, again, a different target on the B cell. This is very similar to rituximab in that it's just the antibody alone. It doesn't carry a chemotherapy payload the way that the polatuzumab does. But again, it binds to the cell and through a variety of mechanisms causes those cells to die. In one clinical trial, this was combined with lenalidomide. The brand name for that drug is Revlimid. This is an oral medication that modulates the immune system in various ways and has been widely used in multiple myeloma, which is a different disease for many years. Again, also has activity in lymphomas we'll get to. But when these two medications were combined, the overall response rate, meaning the percentage of patients that had significant shrinkage of their lymphoma, was 60%. And the progression-free survival, meaning the proportion of patients who didn't have their illness get worse at 12 months at 1 year was 50%. So half the patients in this study still had good control of their lymphoma a year in, which is actually quite good for such an aggressive disease in patients that have had multiple prior lines of therapy. So this was also a very welcome addition to the arsenal in terms of how to treat lymphoma, diffuse large cell lymphoma in particular. And particularly the reason I think this regimen is very attractive is because it's chemotherapy free. This is an antibody therapy, the tafasitamab. The lenalidomide, again, can cause some side effects, including some low blood counts, but in general is very well tolerated, even by older patients. And so, again, particularly in older patients who are not good candidates for very intensive chemotherapy, this is a real breakthrough. I, in fact, earlier this morning, met with a patient of mine who just started on this regimen. He was having very bad back pain from recurrent lymphoma. Immediately, as soon as he started this treatment, his pain went away and he's feeling much better. So I'm optimistic that his first scan is going to show a really favorable response. So this is a really useful regimen also that, again, all of us in the field are very excited is approved. Again, this drug is also being studied in multiple other trials, including some upcoming studies that Rocky Mountain Cancer Center is going to be conducting. So the third treatment for diffuse large B-cell lymphoma I want to discuss is CAR-T, or chimeric antigen receptor T-cell therapy. So this is a very high-tech treatment that involves re-engineering the patient's T-cells to fight the lymphoma. So this is a little bit different than just giving a medication. It's a bit of a process. What happens first is patients undergo what's called leukapheresis, where blood is taken out of their body through a machine that selects out T-cells. The T-cells are then shipped off to the manufacturer that uses a retrovirus to swap out the patient's normal receptor on the cell with a specially designed anti-CD19 receptor. Again, normally B cells or all immune cells have receptors that recognize whatever it is they're supposed to be attacking. And instead of having a T cell that attacks, influenza or shingles or whatever disease it is, this retrovirus removes that receptor and replaces it with a specially designed receptor for CD19. Again, that's a target that Tafasitamab attacks and is the target that's present on all diffuse large B-cell lymphoma cells. Then these re-engineered cells are grown, so they're expanded to a larger set. Those cells are then sent back to the patient, and they're infused into the patient after getting some preconditioned chemotherapy that allows the body to kind of receive these cells. And then the cells will go after the lymphoma cells and attack them. So this is, again, a very high-tech approach. It's sort of re-engineering immune cells to go after the patient's lymphoma. And there's a number of different companies that are developing these, and a few of them have already been approved for the use in diffuse large cell and other types of lymphoma. But the results have been very impressive. This is one example of a trial from one of these compounds. Again, the response rate was 82%. So again, about 80% of patients who received it had objective shrinkage of their tumors. And what you can see is that the patients that had a complete response, which again were about 32% of the total, they had very long ongoing responses. So if patients are responding and these cells are successful in fighting the cancer, they can really keep them at bay for a long period of time. The patients that only had a partial response, unfortunately, with this product in this trial, tended to relapse fairly quickly. So a lot of the research these days in the CAR-T therapy is trying to figure out how do you get more patients into the complete response? Is it possible to improve the responses in these partial responders to get them up to that line to make this a more durable therapy? But this is a very exciting therapy. Again, it's fairly intensive, so probably only suitable for younger patients, under 65 or 70. But this has also been a real breakthrough in the culmination of many decades of research into immunology and gene editing and cell engineering. So we'll move on from diffuse large B-cell lymphoma to talk about follicular lymphoma. Again, just to review, it's an indolent lymphoma. The median survival, again, is on the order of 15 years. Asymptomatic patients with low volume disease, meaning lymph nodes that are not particularly large, can opt for a watch and wait approach where they don't need treatment right away. There is a small subset of patients, 20% or so, have this early recurrence after their first therapy, and those are patients that are not going to do as well as the average. So the first line treatment, again, if a patient and their doctor decide it's time to treat them, patients that have a low burden of disease, relatively small lymph nodes that are involved with the cancer, can use rituximab monotherapy, so just a single agent, which is very well tolerated and has relatively few side effects. For patients with more disease, we want to get that lymphoma melting away much more quickly, and we will add chemotherapy to the rituximab, which is sort of the immunotherapy portion of things. So the next slide just shows some representative examples from some clinical trials. The slide on the left is from a trial of rituximab monotherapy. In this particular trial, they added a second drug called interferon that turned out to not be very effective. As you can see, these two curves are almost overlapping. What this does show you, though, is that rituximab monotherapy is quite effective. So 20 years later after treatment, the majority of patients are still alive. And that, again, speaks both to the slowly progressive nature of the disease and also the effectiveness of rituximab monotherapy. The slide on the right is from a more recent trial combining chemotherapy with one of two antibodies. Rituximab is the lower curve. Again, that was the original anti-CD20 antibody. Obinutuzumab is a second generation anti-CD20 antibody that hits the same target, but it's been re-engineered to be a little bit more effective. And in this study, you can see that the progression-free survival curve is indeed higher when it's combined, when chemo is given with obinutuzumab. Again, the point of this slide, the main reason I brought this slide is just to show again that the progression-free survival is very good for both of these regimens. The median time to progression in the obinutuzumab arm was estimated to be 9 years. So that's a very long duration of response for a treatment that's really only given over the course of 6 months. And so these two are really the standards for first-line treatment. Again, which you would pick depends on a variety of factors, including how much lymphoma there is, patient's age and comorbidities, and things like that. So unfortunately, sooner or later, most patients with follicular lymphoma will have a recurrence, and then the question becomes, what's the next best treatment? So one can always give rituximab again, especially if you got a good long response out of it the first time, and again, it could be combined with chemotherapy. A new class of medication that was approved 5 or 6 years ago is called a PI3 kinase inhibitor. This blocks a certain protein that seems to be important for the growth of follicular lymphoma cells. There's idelalisib, which is an oral medication, and copanlisib, which is an IV medication, but they essentially work the same and have pretty similar results. The two that I wanted to speak about were Revlimid, or lenalidomide, again, which we talked about earlier with diffuse large cell, in combination with rituximab. This was FDA approved last year. And then the most recent approval in lymphoma is tazemetostat, which is an oral medication that was FDA approved just 1 or 2 months ago. And the Rocky Mountain Cancer Center has been involved and continues to be involved in clinical trials of both of these agents. I should mention also that part of the lack of enthusiasm for the PI3 kinase inhibitors is they tend to have a fair number of side effects, including you can see severe diarrhea, inflammation in the lungs, liver inflammation. So these drugs can be a little hard to use, and these two newer treatments tend to be a lot better tolerated in terms of the side effects. So Revlimid and rituximab, which we call R² for short. Again, Revlimid is an oral immunomodulatory therapy, and this is a very effective chemotherapy-free regimen. The response rates, again, the patients that are having objective shrinkage of the tumor by 50% or more is on the order of 65%. One of the pivotal trials was called Magnify, which we opened at Rocky Mountain Cancer Center in 2014. And though that study is no longer accruing patients, we still have many patients in follow-up who continue to get treatment, who continue to have their lymphoma well controlled. And this regimen was FDA approved in 2019 on the basis of data from the Augment trial, which was a somewhat different design, and the Magnify trial, which we participated in. And this is a slide from the Augment trial. In that study involved patients getting rituximab alone versus the combination. And again, clearly the combination is better in terms of the progression-free survival. So this regimen of R² has really become a new standard of care for patients who have had 1 or more previous treatments for follicular lymphoma. And again, it's a chemotherapy-free regimen, very well tolerated even by older patients or patients with other medical problems. Tazemetostat is the last medication I'm going to talk about today. And this is sort of a little sciencey slide over here showing how the drug works. So the slide is showing the normal development of B cells, again, which is the type of cell that follicular lymphoma is derived from. It's called a naive B cell, a B cell that hasn't been trained to recognize something, enters a lymph node. This is sort of a schematic of a lymph node. And in that lymph node, those cells essentially develop and become mature lymphocytes. And then they exit either as memory B cells, which remembers the pathogens, or a plasma cell, which makes antibodies. While they're here, though, if something goes wrong with their development, they can become malignant. This is where the cells kind of veer off track and become cancer. And in this stage of development, which is where the follicular lymphoma cells come from, there's a protein called EZH2 that is markedly upregulated, meaning that protein is highly expressed and is very important for that cell's growth and development. So essentially you have this lymphoma that's stuck with EZH2 being very active, and that makes it a kind of a driver of the growth of the cell, but it also makes it a target that if you could shut this down, you would be able to shut down the growth of the cancer cells. Now, some patients' lymphomas have a mutation in EZH2 that damages that protein itself and sticks it in the on position. But even in patients who don't have a mutation, that protein is upregulated, meaning that it's very active, and it seems like an important part of the way that those cells maintain themselves and continue to grow. So tazemetostat, which is the drug that we're talking about, basically blocks that EZH2 protein. And it actually works very well. I'll show you a slide in a minute with some of the, actually I don't have a slide with that data because it hasn't been fully published yet, but it was FDA approved in 2020 as an agent for follicular lymphoma, and the Rocky Mountain Cancer Center did participate in that trial. Based on that data, we have an upcoming phase 3 trial looking at, again, that R-squared regimen that I talked about in the previous slide, which has become a new standard, with or without tazemetostat, which is supposed to open next year at a Rocky Mountain Cancer Center, as well as other locations around the country and around the world. And again, this sort of combination is typical for how oncology drugs are developed. First, you show that this drug is useful as a single agent, and then you say, well, if we added it to what our other standards are, would that be better, or is it, or not? And that's what the phase 3 trial is designed to show. So that's really the prepared remarks that I have for today. Again, in conclusion, I hope this talk has convinced you that the treatments for lymphoma are continually improving. Really seem to be accelerating in the past couple of years with multiple new approvals. Now for both follicular and diffuse large B-cell lymphoma, there are a number of chemotherapy-free treatment options. And I'm particularly proud that Rocky Mountain Cancer Center has participated in many of these pivotal trials. It's really important to us as physicians that we feel like we're contributing to advancing the field and getting these drugs evaluated and approved if they're effective so that they can get to patients sooner. And in particular, I'm always happy to be able to offer these trials as an option for patients, as a way of maybe getting in on the ground floor with a new, really promising treatment before it's available through insurance prior to FDA approval. So for both those reasons, we're really proud of our research program at Rocky Mountain Cancer Center, both to help our patients individually and also to move the field ahead. So that concludes my remarks for now, and I will check back with Dr. Maimani and see if there are any questions.
Great, David. I really appreciate you presenting all that. Usually we do this live, but due to technical difficulties, there aren't any live questions. So if any of you all watching this after the fact have any questions, feel free to just type away and we'll get those routed to David. So my question for you, David, is the use of Tafasitamab, the CD19 monoclonal antibody. There's been a lot of progress with CAR T-cell and CD19, and I've always wondered, why has it taken so long to develop a CD19 antibody? Do you foresee that in combination with CD20-directed therapy as an upfront treatment option, kind of doing 2 monoclonal antibodies up front with or without chemotherapy?
Yeah, I think that is actually going to be the subject of a study that we're opening within the next 3 to 6 months, I think, at Rocky Mountain Cancer Center, combining R-CHOP with or without the Tafasitamab antibody. So it is certainly possible that there would be some synergy by targeting those 2 different sites on the lymphoma cell. We don't know if it's going to work or not. That's why we're doing the study. But there's enough interest and sort of earlier data from clinical trials to suggest that may be an improvement.
Because it seems like everything that we've tried as far as trying to supplant R-CHOP, hasn't quite worked out for diffuse large B-cell lymphoma, but adding another monoclonal, might be the way to do it, because overall you minimize the side effect profile by adding that other agent. As
right.
opposed to
I would also add, again, as I mentioned, the Polaric study, which was a frontline study of R-CHOP with or without polatuzumab, is being analyzed right now. That study completed its accrual. We put a lot of patients on an RMCC. Again, because polatuzumab was so active as a salvage therapy,
right,
there's some reason to think that it might be, it might actually improve things. But you're right. There's been a whole string of studies of R-CHOP plus X, Y, or Z.
Right.
So far, none of them have panned out.
Right. I don't really have too much in the way of other questions. I think you did a great job of summarizing all the pertinent updates. It seems like with B-cell lymphomas, there's always something new in development in the relapsed and refractory setting, and you've been pivotal in those clinical trials, not just at RMCC, but kind of throughout the U.S. Oncology Network nationally. So, I really appreciate everything that you're doing for our patients, and really expanding our research domain here at RMCC. So if any patients have any questions, feel free to go ahead and type away. And David, again, I really appreciate you doing this.
Yeah, my pleasure. It was a lot of fun. Hope it was useful for everybody, and have a great day.